All right, hi everybody. We will give it maybe one more minute and then we'll get started. A few people are still trickling in.
Don't want to pull a hammy.
Stretching's always good. All right, so I think we can get started, and then we'll just let people come in as they do. So my name is William, one of the residents here. Really excited to have all of you here joining us, and for us to have Nick Brüss today to speak with us. Really excited to have him here, and I'll turn things over to Rob to do an introduction.
Yeah. Well, thanks everyone for coming, and thanks Dr. Brüss for joining us. My name is Rob Palmer. I'm a fourth-year medical student here at Yale, one of the leaders of the group. And I'm super excited, delighted really to have Dr. Brüss come and talk to us about internal family systems and the integration of IFS with psychedelic assisted psychotherapy. I feel like this topic has become just increasingly hot in the last months or last couple of years. And actually, thinking about, I would love to hear someone talk about this. And one of the first people that came to mind was Dr. Brüss, because he actually was one of the first people to introduce me in a meaningful way to IFS several years ago. And at the time, we were working on developing a ketamine assisted psychotherapy program of sorts. And so it's kind of interesting that things are coming full circle now that, several years later, I get to ask him to come give us a talk on IFS and psychedelic assisted psychotherapy. So I'm super excited. I hope all of you are as well. And so without further ado, let me introduce Dr. Brüss. I'll give a very brief introduction and then turn it over to him. So Dr. Brüss is an integrative psychotherapist specializing in helping people with psychedelic assisted therapies. He was trained by MAPS and is a therapist on the phase 3 MDMA assisted psychotherapy for PTSD trials out in California. He's certified in both IFS and ketamine assisted psychotherapy and has provided ketamine assisted IFS therapy in LA, Los Angeles, since 2017. He's also the co-founder and lead trainer of the Psychedelic Coalition for Health and the clinical director of psychedelic therapies at Hope Integrative Psychiatry in California. So I'm super excited to have him here. One brief note on housekeeping. Please just save your questions for the end unless it's a super urgent, needs to be clarified before we proceed kind of question. We'll have a Q&A at the end and we'll go over kind of the format for that once we get there. But for now, just keep yourselves muted so that we're not getting any kind of audio interference. And without further ado, Dr. Nick Brüss, thanks so much.
Thank you. Soon to be Dr. Palmer. Rob, thanks for having me. Will, nice to meet you. Glad, really excited to be here. Yeah, as you said, Rob, it was 2016, 2017, that time in Lameda, and really kind of seeing what was coming down the line, and ketamine in particular, which we'll be discussing some today. I am honored and humbled to be asked to participate. I've seen the caliber of presenters you've had before, so I hope to do well by you. Today, we will be talking about internal family systems, how it interfaces, blends, does this beautiful dance with psychedelics, particularly the ones I've been working with, ketamine and MDMA, and we'll have time for a discussion at the end. A little more about me. Thank you, Rob, for the introduction. So went to CIIS, which is kind of like the Yale of transpersonal schools. Certified in IFS, I've done a lot of training, I've been an assistant at trainings, ketamine assisted by a group in Northern California and Colorado. As mentioned, a co-therapist on the phase 3 clinical trials for MDMA for severe PTSD. volunteered with Zendo, have run spiritual emergence or psychedelic integration groups, and aforementioned Psychedelic Coalition for Health, which really excited about, and we actually have a very large symposium coming up with names that you guys will likely recognize. Rick Doblin, Dick Schwartz, who's the founder of IFS, Gabor Mate, Paul Stamets, Tim Ferriss, Rachel Yohida, there's the list goes on. Who are also offering a clinical training for professionals for psychedelic assisted psychotherapy. That's happening this fall. So here we go. Pretty sure everyone in this group knows a bit about psychedelics. Just a couple notes here. They origins predate written history, powerful substances, altered states of consciousness, affecting a number of cognitive processes, including perception and mood. Generally considered safe psychologically and generally non-addictive. So why get the assist from psychedelics? And these are in very just layman terms, heart opening. And majority or most of my comments will be based on ketamine and MDMA. And I'll be clear when I'm kind of reaching or honed in on a different psychedelic. Heart opening and an expansion that helps us feel. You might agree that most of suffering comes about in relation to resisting feeling what's here. And so this helps us, psychedelics can assist us in psychological flexibility, tend to foster self-compassion, quiets the default mode network, which we'll get into, our ordinary mind, or even just taking a break from the ordinary mind. And it can kind of mimic near-death experiences, which can be a real big shift in perception, which can create new reference points, which I'd like to say here early on to talk about integration. Integration as part, it's the decisions, the choices we make in our life that are now informed by maybe peak experiences or just the work we're doing with psychedelics. And yeah, to make meaning, have purpose. You'll be hearing more about meaning making experiences and the utility of that. So catalysts, these are catalysts for change or growth. And this happens on a multiple levels. So on the biological level, and I'm thinking ketamine right now, decreased inflammation and pain relief. It takes a lot of energy to carry around pain. I mean, and physical or psychological pain. So when we can get a break from that, it creates a space to do healing and make some shifts. You're likely familiar with some of the research around the neuroplasticity and neurogenesis of several psychedelics. This image is a pretty popular one. It is the communication between brain networks and people given psilocybin and the other a non-psychedelic compound. You can see which one is which. Psychological components. So there's a lot here, but it assists us in knowing ourselves better. And part of that is seeing patterns. And when we can see patterns, then we can interrupt patterns. We can make other choices. A new perceptual reality. This can have an example of this is if you've gone somewhere else in your mind, or you had this different experience that just didn't fit into the life you were living or the experience of yourself that you were having. It's an opportunity, a novel opportunity to expand, to include that experience. And likely those tend to lead towards social, pro-social behaviors. If for a number of psychedelic medicines and higher doses, there can be a very big experience that not only blurs the line, but actually expands the small sense of self to being part of something bigger, which turns to pro-social activity and also pro-environment or pro-environmental behavior as well. And then on the spiritual or consciousness level, mystical experiences, again, they create an opportunity to for more information to arise that gets incorporated in a way that leads to positive outcomes. So why this combination? Kind of speaking to the crossover here, although they, as already mentioned, they both can do this, invoke self-compassion, stoke awe and hope, relaxes both the physical body and the psychological defenses. They both, or I should say, so the way that my colleagues and a lot of the research is setting up protocols is to honor the inner healing intelligence. In IFS terms, we'll call that self, as you'll see. Grief and gratitude, this is just naming like some of the range of which human experiences that can come up and be welcomed and worked with, as it's not only healing and kind of letting some things go or forgiveness, or integrating, making room for different experiences, but also empowering by way of having more insight that can then be turned into lifestyle changes. And then self-love. So just to talk about IFS, it helps us know ourselves more. And if you're like me, you've both heard that, oh, you have to love yourself before you love somebody else. And at the same time, at least I have never been told exactly how to do that, how to love oneself. My work personally and also professionally with internal family systems is the most tangible way I've found to bring about more self-love by being aware and becoming more intimate or knowing more deeply all the different aspects of myself, or whichever aspect is up, even a critical one, even one that's blaming or shaming. I get to know myself more. And through this inclusion, it feels a lot like love. Okay, IFS. In the late, I got turned on to IFS through this book, Wisdom and Compassion in Psychotherapy, in 2012. There's a section in there about self, no self. This is very interesting, and I was hooked right away, and I searched for where I could get training. And back then there were many trainings available, and unfortunately, this talk comes with a warning. I heard last week that there's quite a wait list for training, but I encourage if any of you are inspired or intrigued to do get on the wait lists and find other ways to get some training in IFS. Late 80s, Dr. Richard Schwartz, he goes by Dick. He was in academia, University of Illinois and Northwestern. He was writing textbooks on family systems, this model of working with the complexity of a family, literally like having the family in the room. And if there was a conflict, he might have somebody shift or walk over here and work with the family dynamics in different ways. And along the way, he found that essentially that wasn't working with a number of individuals. Part of his work was at a eating disorder clinic, and through all of his might, he tried to kind of reorganize or help people reorganize their internal worlds, and it just wasn't working. And then he began to really listen, and he was taught, Dick would say he was taught about their internal family systems by what his clients would share with him. And we'll be getting into that. Year 2000, started the Center for Self-Leadership. That's the training organization. And just to know that IFS is evidence-based. And I threw in this at the last minute because it's something I wanted to say early, which is just the acknowledgement of parts and burdens that those are separate. I'm going to come back to that, but that can be healing in of itself, meaning that a lot of different therapies, or just left to oneself, we can, if we notice a part of ourself, say the most popular one out there, a self-critic, that if we notice that, we often are instinctually just kind of want to get away from it or make it go away. We can combat it or try to destroy it or try to trick it. What we come to learn, not only through learning about this model, but in one's own experience, is that if we turn to each of these parts, the parts themselves are not bad. I challenge you to find a part that ends up turning out to be like bad. Rather than that, we'll find that they carry a burden, or they're in an extreme role. At their core, they will be looking to serve you. Handful of basic assumptions. So multiplicity of minds. And it might ring out to you right away. And if you've not heard much about IFS, how this fact alone, this aspect of the theory or the model, really lends itself to working with psychedelics. So it holds that we all have sub-personalities called parts in this model, and that there's also, and that's a natural thing. And I would add that this is how we learn to be in a relationship. We have dialogue with people around us. And in a way, you can think about IFS as turning that dialogue to different parts of yourself and relating them in the same way that you would someone outside of yourself. Also holds that everyone has a self. We'll talk about this, but this is a core essence that everyone has access to. There are no bad parts, only ones with extreme roles. And I mean that even to the extent of suicidal parts, the parts that say they want to kill you or yourself. Similar to external family systems, there's complex interactions of different parts. And we'll talk about this polarizations and kind of what they're up to. Carl Jung was on it. His quote, "Wholeness is not achieved by cutting off a portion of one's being, but by integration of the contraries." So that's what we're doing with IFS. It's the goal. Balance and harmony within the system is the goal. And to do that, we need to differentiate self, which we'll learn more about, self from parts. So self is not a part, and we want to be able to be discerning and notice the difference. And then from there, we want the self to lead. Different than being led by one part of you. Mentioned before, all parts welcome really makes this a powerful modality. Things that seem like a distraction, an obstacle, an interruption are not in this model. They're just the next thing and the next part that's needing your attention. One example with some somatic therapies, of which I'm also trained in, and I have a lot of respect for them. I've seen a different way of working with IFS. Sometimes if there's something that seems overwhelming, or just if for whatever reason a client is feeling overwhelmed, some therapies would kind of throw a call to like have that person ground, breathe, orient to the room, which in ways is really useful. The IFS model would welcome, turn towards the overwhelm and get to know it more. So all parts welcome. Parts, most simply, are inner sub-personalities that we relate to in the same way we do other people. There are three main categories: managers, firefighters, and exiles. These first two are also classified as protector parts, and they're protecting against exiles, this third kind of part, from emerging. And you'll learn why. Managers. And as I'm talking about these, you might relate to some more than others. These are the protectors of the system. They're really wanting things to stay functional and safe. They're strategic. You're going to learn that firefighters are reactive. These are strategic. Again, their job keeping exiles at bay. A little bit more about managers. So it can be ways of numbing oneself over a period of time. It can be that self-critical voice that keeps you from giving a presentation, any number of things. But the main piece, and I'll give more examples later, but that they have this strategic component to them. Whereas firefighters are reactive. So think, firefighters are kicking it at the firehouse, the alarm goes off, a big feeling, shame, fear comes up. They zoom in, hoses, douse the thing, they kick down doors, break windows. They give zero fucks about any damage or anything that goes on. Their job to put out the flame. The intensity of the exiles' feelings are often these flames. So it's their job to keep them away or put them away when they arise. Highly impulsive. They would, so you can imagine a guy feels rejected and then he starts to rage. So rage would be that firefighter part leading that charge. A person feels shame and then they binge on eating. And there's a lot of examples. Important point, the managers and firefighters are often polarized with each other. So kind of a tug of war. Like if the managers aren't doing quote unquote a good enough job, then a firefighter might pop up just to be sure. Or the managers can tighten up in fear of even the firefighters doing something that then maybe damage a relationship. Talk to managers, talk to firefighters, exiles. These tend to be young parts. They carry the emotions and memories and sensations from experiences of being hurt, scared, or shamed, or neglected. And what is needed, what's missing, is they need to be seen, heard, and felt and understood by you, yourself, capital S self. That is where integration and healing lies. These are usually the most sensitive and vulnerable parts. So if you imagine a 3-year-old, very sensitive, vulnerable, they're also usually the most playful, innocent, and intimacy loving. And the name comes from an experience in which the part, again, the part is not a problem, but which a part took on an extreme belief where there was something too much, too fast to hold, like a traumatic experience or a repeated experience that was just too much for a young person or a young nervous system. On to self. Self is not a part. Self is inherent in everyone, inherent existence of a spacious essence, which sounds kind of vague, but it's the you that's noticing these different parts. When you've kind of caught like some self-criticism and you have even a little bit of space from it, you can notice the difference that there's a observing presence that's noticing these other parts. The the metaphor of the sun behind the clouds, it's always there, even if we are totally hijacked or blended with a part. The self energy is still there. And again, the self is the one we want leading. More on self, there are these 8 characteristics. They all happen to start with the letter C. You can see them there. And then 5 more P's. And this is also a way to know if you're being led by self or by a part. It's not that some parts won't have some of these qualities, but if you're but these qualities are present when you're in self. The IFS process, what's novel about it is it's human organization on multiple levels, psychic, family, and culture, the same systemic principles to intervene at each level, same ecological techniques. So what Dick Schwartz found useful working with families was in ways able to be applied with some adjustments to the individual. And just a little bit about the process. So my job as just in the IFS therapist role is as a part detector. I help people recognize, identify parts, which in doing that also highlights themselves, who is noticing them. So we're detecting parts, and it's different than other therapies. It's almost like a training of how to know yourself and how to be with yourself and how to work with different parts. We access, or we kind of go into and get to know different parts. Unblending is a big phrase in IFS. There's the self, and when we're in the seat of the self, that's who we want leading. A part, for any number of reasons, can blend with you or hijack, or another way to talk about it, be identified as just this part of you. So if you're upset with your friend, in a single moment, it might seem like all there is like frustration or upset. And a breath or two later, you might feel like, wow, I'm really upset, or part of me is really upset. That puts you back in the self leadership role. And then you can tend to the part that's active and even speak for that part in the conversation. And that's also a useful phrase, speaking for parts, different than speaking from parts. So the idea of like blind rage, that is just a part leading the whole show. There's not much self present there. Whereas we can be in a heated argument, and the difference of saying, I'm so pissed off at you versus part of me is so pissed off at you, it already starts to leave a little bit of space that I'm aware of this and I'm speaking for it rather than from it. We get permission as we go, which is also very trauma informed. We're addressing whatever's arising. Unburdening is a process where, as we get more intimate with these parts, we can help them let go of what they've been carrying. It's an updating kind of system. Whereas you, as a 5-year-old, might have been in an environment where sadness was just not welcome and maybe even punished in that environment. And because it's an early track laid down, and because our drive for connection will override our authenticity, we'll start to find ways to not express that. And as an adult, or even as a young person, we can update our system that it doesn't have to be like that. And it's not so much a logical, cognitive thing. It seems like, if to imagine it, it would be like a older person or an adult sitting down and explaining, but really letting a younger person know that it's safe now. It's a different situation. There's an invitation component, and of course integration, and appreciation is much a part of it. Right. One finer adjustment on the IFS process, these 6 F's. So there's steps to help protective parts differentiate from the self or unblend. First is to find. So we can locate the part in or around the body. So it might be a harsh critical voice, and you can kind of locate that kind of takes residence somewhere in the chest or the stomach, or shoulders can be really tight. So we'll find it in the body or around the body, and we'll focus on it. We'll choose to turn towards, whereas what might seem more natural is to get away or kind of go to battle with it. We'll focus on it, flesh it out, get to know it more, begin to ask it questions. And this very important question: how are you feeling towards the part? So I'm sitting with someone, I'll really make the distinction, I'll use Rob's name. Like, how are you, Rob, sitting there? How are you feeling towards that part? And again, I'm kind of assisting and helping out that, oh, I see you, Rob, and I'm facilitating this conversation with you in this part. And what might happen from there is Rob might say, I'm pissed at it. And I'll say, okay. And that's clearly another part. So I'll then invite Rob to just focus to that part that's really critical of this other one. And then we'll be working from there. This is like a litmus test to see if the person is in self, and it helps guide the sessions. And then we befriend. We really get to know it more, asking it more questions, and particularly what does this part fear? Again, we're dealing with protectors. Protectors, they might have opinions, but we want to get to their actual concerns or their fears, because once we get there, then things can start to move, and we can simply ask them. Once they're heard and feel felt, they will step aside. Who's IFS for? This is a long list: trauma, anxiety, depression, substance abuse, eating disorder, shame, it's great with phobias, transitions, or around clarity. Part of me wants to quit the job. Part of me wants to do this. We can, sometimes these parts don't even know the other exist. We can easily facilitate a conversation of what these parts have going on and their concerns. And overall in life, again, it kind of helps us know ourselves better, which is a good thing. So wrapping with the IFS only portion of this, know that it's also a non-pathologizing model. So we could go through the DSM and you could have all this criteria. The DSM, the Diagnostic Statistical Manual, it's all the lists of things for people to be diagnosed with. And we could see and start to name what different kind of parts are active in these different diagnoses. And we don't do that in IFS. It is strength-based. So you're connecting with this innate healing intelligence and working with that source. It's collaborative, not only therapist to client, but client or self to parts. It teaches self-regulation, not in the way of like, oh, that's too much, I have to get rid of that, or I have to check out, or I have to do the things that helped me in childhood to do, but rather, oh, that's up, that's intense right now. What are the ways I can stay kind to myself? It's actually maybe turning towards that part and getting to know it more. And then more options come from there. Towards the end, get into the window of tolerance and an IFS perspective on that. And this work fosters compassion, and just seeing it consistently. And the experience of differentiation, of knowing like, oh, that's just a part of me. We can have some horrific verbiage or ideas come up. And as we get to know, like, wow, part of me is really scared and he's throwing up these gnarly images. As we get to know that, there can be relief. You don't have to act things out because you can stay in yourself. And just tossing this in is around like all parts welcome. Dick says this is a constraint releasing model. So anything that arises, it doesn't become, it's not a problem. You don't have to like go around or get rid of anything. We can get to know it, and it can release ultimately by its own accord. So allow me to introduce you to ketamine, and just naming that Raquel Bennett gave a wonderful presentation to your group. I think it was a couple of years ago now. So for those of you who haven't seen that and want more on ketamine, I watched it not that too long ago. It's still all very, very relevant. Ketamine's been around, 1962, created as a surgical anesthetic. It's on the World Health Organization's list of most essential medicines. It's used worldwide. By class, it's a dissociative anesthetic, which means it creates this experience of having space, distance from one's body. And to say that the therapeutic doses are all sub-anesthetic. So you're not, there's still a consciousness presence online in the therapeutic doses. Became Schedule 1 in 99, I'm sorry, Schedule 3. And there are multiple routes of getting ketamine into your body. We'll get into that. It's mostly used off label for these purposes because it was created as an anesthetic, although in a couple 2 years ago, there was one version, intranasal spray for treatment-resistant depression. And it's generic. It's dirt cheap as far as medicines go. What's so special? It is super safe and has a great safety profile. And by that, I mean it doesn't depress the cardiac and respiratory systems in the way that, say, morphine or other things do. It eases pain and panic for most. It was called a buddy drug. So in the Vietnam War, if a soldier was injured and needed to be evac'd or transported out, in the meantime, he was given ketamine. He was often given ketamine because it would, one, help him with the pain, create some distance from the pain. It would ease some of the panic. And it didn't have to be as closely monitored as, say, in morphine. His heart rate and respiratory system were safer with ketamine. Antidepressant effects have been known for a long time. It has this amazing, pretty immediate reduction in certain types of suicide ideation. Ketamine, although my mind also thinks of a number of other psychedelics, but sticking to ketamine right now, it can be a pattern interrupt. So it's a catalyst for change. With therapy, a feeling of stuck, and just if you're a human, I'm pretty sure you've felt stuck in a number of ways over time. And ketamine in particular doses can help shift or be either a lubricant kind of for a therapeutic process and or kind of help with a shift out of stuckness. In IFS terms, it's softening protectors. But we want to be clear, and I'll get into this, about how we need to ask permission for protectors before working with ketamine or any psychedelics or any drugs prescribed or otherwise. Ketamine opens up this space that we can reperceive distortions or limitations. There's something to this, creating a little bit of space between your body and what's arising. So there might be a voice that you hear quite consistently. I'm only good enough as my last whatever thing I did, or if I don't make these grades, I'm, whatever. To hear that same phrase, but with a little bit more distance, it can stir something, it can strike something. It's like, I'm over here, and there's that thing that I normally hear, which I normally identify with, or I normally get in a blended with, or then have to try to outdo in some way. So it can create that space for that experience, which can create reference points or new reference points. And this is, again, like for integration, it's like how we take these reference points and have them show up in our daily lives. One example, a client who it's quite beautiful and said, "Oh, so this is what I'm like without depression." And while it was, that window was maybe 20 minutes or so, he then had not only the taste or the reference point of that, but that taste alone was inspiring and encouraging for him to work out more, to do a number of things that he knew he had known before we started working with ketamine, but he was more motivated to work towards that. And then enhances neuroplasticity. A brief comparison to some of the classic psychedelics. So ketamine compared to LSD, psilocybin, and others, DMT. Some of the similarities, non-ordinary states can be achieved, particularly in higher doses. A sense of oneness, oceanic bliss, unity consciousness, that's all possible. It can bring unconscious material to the surface, which, as you can imagine, is useful for therapy. Some of the differences, it's a dissociative. So while some of the classic psychedelics can heighten some sensations in the body, this one actually turns down the volume and the sensations or even your experience of your body. And it can create a little bit more spaciousness where emotions feel muted, though accessible. Quiet signals, mitigates pain. And yeah, I don't want to skip over that quickly. To have a relief from pain, let it be physical or psychological. If you've been carrying around something and it can just be set down, yes, by the aid of a medicine. And then in that space, you're able to feel more compassion for yourself for having carried that, having had to carry that. That's a beautiful thing that can go a lot longer, years or decades longer than the short half-life of ketamine. And then another difference neurologically, ketamine works mostly on the glutamate pathway in the brain, different than serotonin or dopamine, and mentioned short half-life. Question I get a lot, so what does it feel like? The short answer, for most people, it feels very pleasant. People feel relaxed. There might be a wave of anxiety that can totally happen, but for most people, most of the time, it lifts mood. And then from there, it really depends on the dose. So the lower doses, I describe it that the alteration in consciousness is similar, not the same, but similar to a couple glasses of wine, where it's like, okay, a little tipsy or something, it's not quite the ordinary way we're seeing the world. In the higher doses, similar to other psychedelics, it can be as very much like a ride or a journey, another dimension. You can die, be reborn. The actual high dose experience for very much most people is very still and inner, and they report kind of the places they've been. One place, so this is an image from Inception. One experience I had during training was a higher dose, and similar to these movies, Inception, Interstellar, where you're kind of seeing these visuals, and you're like, whoa. That and the next 5 of those that haven't even been made yet that are going to blow your mind, that's part of the ride that I went on. Another part of that ride was I was clearly dying, or it wasn't actually dying, it was just leaving, not coming back to the life that I knew. Was totally fine and okay with that. And there's a lot of insight to be had. I'll just add this here. As we're coming back, as the medicine's wearing off with ketamine, and you notice your body come back online, there's a lot of rich information there, like how we've been relating to our body. You can even notice how relationships come back online. I'll say more about that. So I have some other quotes here, but this one was from a client who journals after sessions. And this was actually a relatively low dose, and he wrote this in his journal. I started tonight's session with the intention to explore my relationships with control, exploring the ways I use control over external things to make me feel safe. Throughout the session, I felt a recurring feeling of being both whole and tossed around. At one point, I felt like a bottle floating on a rough ocean. Later, I felt like a blade of grass blowing in the wind. Yeah, with the tossing and the blowing, I felt whole and complete. And as I am sitting here hours after the fact, still tingling and in awe of how keenly aware I am of my own inner peaceful space. The waves in the wind were neither good nor bad. They just were another example of how ketamine therapy has been a masterclass in exploring my parts and opening me to meet whatever arises. Again, that particular session, we were in conversation majority of the time, with periods of him just going inside and being with his direct experience. What can it treat? There are some well-researched things. Those include some forms of depression, some forms of anxiety, including OCD, some forms of suicidal ideation. And everything else, it's safe to say, needs more research, although there is more and more coming out. Just to pick 2 that I'm particularly interested in is psychospiritual exploration and couples and group therapy. Ketamine assisted psychotherapy process. So it typically starts with a couple meetings, and then if we feel that ketamine might be appropriate, refer to my colleagues at Hope Integrative Psychiatry in Los Angeles for a full medical screening by a psychiatrist, integrative psychiatrist. And we do a number of prep sessions before introducing ketamine. Then the actual ketamine sessions, about a double session, 2 hours long. And this is the way I've been working most often recently has been virtually, where a client has the ketamine in their home, in their space. They have an ally, not necessarily someone in the room, but someone very nearby that I have contact information, and they're kind of on standby. And then over the course of this 2 hours, there's an arc of the ketamine experience, of which, and with these doses that I'm referring to now, it stays conversational, relational mostly. I always follow a ketamine assisted session with a non-ketamine integration session 1 or up to 3 days later. And at the end of the period of working with ketamine, we'll do several sessions of kind of wrapping up that bit of work. Safety, I could say a lot about this, but detailed, informed consent, discussing every bit of it, getting permission from parts. So with IFS in of itself, we don't blow past or sneak around or bully any parts. So we get permission, and the same is true for working with ketamine. Logistically, just no food 4 hours prior to session. That's to mitigate nausea. The final, if people go to the bathroom, is the last thing they do before we start a ketamine session. I had a big family, and my dad would announce to the house before we leave the house, "Take the final." That means go to the bathroom one more time because he's not pulling over. So, and the reason for that and why it's here in safety is that's one of them of the concerns of working with ketamine, is that people would move around with when they still have ketamine in their system, and they're just more prone to fall if they're on ketamine. So we want to take that timer out of the ladder. If I am meaning high dose and intramuscular, then a medical professional will be there in the room and taking vitals, Zofran used as needed, or to pre-treat nausea. And of course, they commit to not driving the rest of the day, even if our session is earlier in the day. Setting intention, I ask, it's really those preparation sessions where I'm we're getting to know goals and aims, yes, but also different parts, and kind of mapping out a person's system so that we know the territory. Some of these questions come up. What do you want to get out of this? What do you need, or what's your attention right now? What direction are you heading? And again, these preparation sessions, they'll also get a practice of going inside and connecting, finding those 6 F's, finding a part, focusing on it, fleshing it out, and how you feel towards it. So they already have that practice, because it does come up in ketamine assisted, ketamine assisted IFS sessions. So they already have that practice. And then I am certain to mention or discuss the difference between intention and expectation. Expectation, goal-oriented or outcome-focused, whereas intention is more about the process and how do you want to be with yourself? What's the longer-term aim about a way of being? And of course, we're always going to explore whatever's here. We don't have to fight or wrestle, or if it doesn't meet an intention or an expectation, need be no struggle. and exploring things that can come up: unprocessed grief, addiction, or the roots of addiction, anger, trauma. And then one other thing: profound insights and perspective can happen with or without words. With some regularity, clients will report having felt a shift, or in particularly letting go of something that they can't quite put words on, or they don't know exactly what just fell away. Majority of them have a sense of what that is in the days or weeks to come. And even for those that don't, and I've been working with people a long time that have kind of followed up, and it was so juicy or interesting about what fell away. We check in, and there's people, months coming up on a year later, where clear something fell away, still doesn't know what it is, but has the fruit of whatever that is being freed up. And of course, setting a real care given to the physical space and safety. Of course, physical safety. All right. Checking in on the time. Ooh. Wow, I'm going to speed up. Administration, there's several ways here: intravenous, neuromuscular, sublingual, intranasal. The bioavailability is is an important consideration here. IV and intramuscular have 97+%. Kind of how much ketamine you're getting. Ketamine is a very small molecule, breaks the blood-brain barrier very easily. It's about getting the ketamine there. Sublingual, intranasal, I hear numbers between 20 and 50%. So I work recently more with sublingual, so it's just a consideration of the work of which administration. The dose, psycholytic dose, these are the low dose, typically with lozenges, kind of softens or lightens the state. This therapeutic kind of lubricant. Protector part soften, stays mostly relational with periods going inside. The higher doses can be with lozenges, but more often with intramuscular, partial to fully dissociative, which means they may not feel their body at all. Mostly an inner experience, and the processing of the psychedelic dose tends to be on the other end. Person tends to be very quiet and in their experience. Preparation, I've already talked a little bit about, but the real invitation to surrender, a heads up that it's likely not going to be a linear thing. It's not going to be, we're going to keep a conversational valley. We're going to go inside, and other things are going to come up, and we're going to turn to them. The ordinary mind, or a decrease in the default mode network, can fade, so that can be a different experience for many. I mentioned getting permission. Subconscious material or less expressed parts can have a space to get voiced. And then, just like regular IFS sessions, letting them know in the lower dose sessions will be inner directed. And very important, letting people know, even if they've worked with ketamine before, that no matter where they go, I'm referring to the higher doses, no matter where they go, whatever dimensions, galaxies, or scenes of trauma, that they will be back safely in the room in about an hour. The intention is a big part of the preparation. Integration starts with preparation in ways, the way I treat it is not different than IFS, in that if I'm working just with IFS without ketamine, parts can come up, and parts can come up when working with ketamine. And part of integration practice can be setting up, even scheduling, literally scheduling meetings with these younger parts, or these parts that arose, even for a couple minutes throughout the week. So it's kind of continuing that work and building a relationship with different parts. Reference points, as we talked about, and the choices that you make informed by the medicine sessions. How do you bring those into your life? And then this is just, please work with someone if you're interested in working with ketamine, and at absolute worst case, talk with someone who's trauma informed along the way. Wrapping up the ketamine, legal in all 50 states, it's safe, it tends to boost mood, fosters insights and compassion, has this ability for a lot of perspective. One of my clients calls it the ketamine perspective, and she could be in a a battle royale with her husband, and she'll ask herself, she'll even ask her husband, like, what's the ketamine perspective on this situation? It kind of automatically slows them down a little bit and creates a little bit more space, more access to material, and gives a break from ordinary mind, stokes awe, mystery. And this is a important piece, as I've mentioned before, the novel experience. It's prime for meaning making, to bring more purpose or understanding into our life, which can fuel us and carry us through challenging times, because it is tough being a human sometimes. Okay. Right. So, and MDMA, I'm going to talk briefly about a history, talk about what it is, why, and what for, and then we'll get into the discussion. So the history way back in 1912, I believe it was in Germany, the Merck company, pharmaceutical company back then, they were trying to create like a blood thinner. Didn't work out, but they ended up with ketamine, didn't have a use for it. I'm sorry, they ended up with MDMA, didn't have a use for it. So it just was patented and it sat for a long time. In the mid 70s, Alexander Shulgin synthesized it and also introduced it to a lot of therapists in Northern California and beyond. In the 80s, ecstasy, which has, important to say, tends to have MDMA, but almost always is cut with something else. So there's some other substance with ecstasy. So we're just really trying to pull those apart. There's ecstasy and there's MDMA. And yeah, an important piece. So the DEA stopped the party, or scheduled MDMA in '85. And even before that happened, Rick Doblin, the founder of MAPS, saw the writing on the wall, and he created or launched MAPS, the Multidisciplinary Association for Psychedelic Studies, that same year. And it was and is currently still MAPS' primary project to have ketamine rescheduled. Wow, I guess I say ketamine a lot, but I'm meaning MDMA, having MDMA rescheduled. In 2000, the FDA approved a protocol. 4 years later, the DEA said, okay. Same year, the first participant was enrolled. And 12 years later, 6 phase 2 clinical trials happened. In 2017, the FDA gave MDMA assisted therapy a breakthrough therapy designation because it was so outperforming other treatments. Excuse me. Phase 3 began in 2017, and I feel very fortunate and delighted to be a part of the phase 3 study. We are in the second half of the phase 3 study. Hope to have it completed in 2022, and by 2023 have it rescheduled. Okay, so what's going on with this molecule, ketamine? Ketamine, I'm looking at MDMA and I said ketamine, funny. It increases neurotransmitters, as most people know, serotonin being the big one, also norepinephrine and dopamine. Enhances the release of hormones, oxytocin, lectin. And the gist of what's going on in your brain, as best as we know, is that it decreases activity in the left amygdala. This area of the brain associated with fear and traumatic memories. So it's decreasing fear and defensiveness in terms of IFS, softening the protector parts. And at the same time, increasing trust and empathy. That's not surprising, right? Fear and defensiveness go down, trust and empathy up. So the therapeutic approach for MDMA assisted therapy While it was manualized as it needs to be for a FDA-approved study, it was influenced by Stan Grof and Dick Schwartz. But Michael Mithofer, who is a primary principal investigator for many of the studies and most of the manual, he and his wife Annie are both IFS trained, but they were specific in not making IFS the psychedelic modality. They wanted to see just MDMA and a non-specific therapeutic modality would do with PTSD. So what they came up with, some of the therapeutic approaches that would be non-directive and since become talked about more as inner-directed. So as a therapy team, a therapist, we really trust the inner healing intelligence of the person that we're working with. And we keep directing them back to their own inner wisdom, that source of healing inside. We consistently support the emerging experience, not sitting there with an agenda of how things should go, really meeting what's arising. And as you've heard, there are no obstacles that we work with, whatever's arising, and all parts are welcome. And the shortest kind of tagline and the way I do all my work is a curious and compassionate stance. All right, winding down. So a couple of fundamental avenues of healing trauma, and this is from Bessel van der Kolk. Talking top down is one of the avenues. This is talking a logical approach, learning how one is interpreting information. Another avenue, and this is like most talk therapies, another avenue is working with medicines that turn down the alarms or the reactivity in the brain centers that are associated with that. And the third way, or a third way, is bottom up. And so this is a somatic approach, working with experiences and ideally having experiences that contradict the impact of trauma. And just so happens, MDMA does that. MDMA assisted therapy does that as well, and that as well. Okay, we got 2 or 3 more slides. Mentioned I wanted to come back to this. So window of tolerance, this is working in therapy in general, also very much with trauma. This is developed by Dr. Dan Siegel. It highlights the optimal kind of zone or space for someone to be in themselves. Whereas the higher end of it, the hyperarousal, I think fight or flight, emotional reactivity, overwhelming sensation, intrusive thinking, intrusive thoughts, or the lower end of this window, the hypoarousal, is being like numbed out or frozen. Many psychedelics by themselves facilitate people to be in this window or increase the window. So if your fear centers in your brain are turned down, that optimal window just got wider. In terms of IFS, that center zone, we consider that self energy. That, and you saw those C words before: curiosity, compassion, clarity. You've got the space to be with what's arising. Whereas the high end or low end outside of that optimal zone, you'd be blending with either exiles are getting too close or firefighters are getting active. There's a certain hijacking of one's presence. And on the low end, likely managers kind of shut things down in order to stay safe, to keep you safe in some way. Last one, MDMA from an IFS perspective. You've heard some of this, so it increases self-energy. The molecule increases self-energy, lowering fear, more trust. It's often very pronounced in MDMA sessions. It brings out these C words as part of people's experience. It also increases awareness of parts, kind of softens protectors, makes unblending more more possible or with more ease, because there's simply more trust and more relating happening. Okay, and I just wanted to kind of refresh this one as we end this portion of psychedelics as catalysts and why this combo. And that's it. Thank you guys for your attention. Much appreciated.
All right, Nick, thanks a lot for the presentation. We've got some time for questions. I think a lot of you are already familiar with sort of our approach to the questions, but if you do have a question, use the raise hand function and we'll call on you and you can ask it. Or if you don't feel comfortable asking it, you can put your question in the chat. But we will give preference to people who raise their hands because it's great to see your faces as a part of the conversation. So with that, let's open it up. If anyone has questions, you can raise your hands and we'll get started. All right, so I see we'll start with Sam Coe.
Hey, Nick, can you hear me?
I can. Hi, Sam.
Hi, thanks for the great discussion. My question is regarding, MDMA is going to likely get FDA approval, and with nasal S-ketamine, they had this risk mitigation policy, for example, like observing the patient for 2 hours, not letting the patient take it home, et cetera. And I'm curious, do you think, what will that look like as far as that risk mitigation strategy for MDMA, assuming it becomes FDA approved?
Yes, let's assume. And do all the hard work, continue all the hard work to get there. Thanks for the question. Here's what I know so there's MAPS, a nonprofit, and MAPS launched a B corporation solely owned by the nonprofit, and the public benefit corporation is kind of the pharmaceutical branch of it. So as as MAPS has done the $30 million that they've put into sponsoring these trials, part of what they get, as I understand it, is it's 5 to 7 years exclusivity of selling MDMA. And the way that they're rolling that out, to me, it's quite ethical that they are only going to be selling MDMA to therapy to teams that meet certain criteria. I don't have all the details of the criteria, but training right now, the MAPS training, and there might be some other trainings that qualify, that you won't be able to go to any doctor and be like, it's time for MDMA, and my therapist is on board, and my psychiatrist wants to prescribe it. There will be that check that it comes in a package, that there's a trained therapist. You will not be able to just take MDMA home. So that being a way that they are doing some checks, at least for the first 5 to 7 years. Did that answer your question?
Yeah, so it seems like they're going to have certain regulations that come from the MAPS protocol, is what I'm hearing.
That's right. It's unclear if it will, or maybe it's unset, if it will have to be a therapy pair in the room all the time. But yes, they'll be setting that standard.
Got it. All right, thanks so much.
Got it.
All right. The next hand I saw up is David Matai. Forgive me if I mispronounced your last name, David.
All right. Thanks, Nick. Thanks, Rob and William, for organizing too. Nick, I really enjoyed the talk. I'm from a more traditional psychiatric model, so a lot of thinking about IFS is new to me. And one thing I think I'm struggling with a lot is this idea of being at the cusp of a really challenging experience, sort of at the verge of hyperarousal, and then going in deeper. It feels like counter to a lot of risk management, safety sort of thinking in psychiatry. And I'm curious if you have maybe an example or a case of what that looks like in practice.
Mm-hmm. Thanks, David, for the question. I hear you. Like on paper, it's like sounds like a bad idea. And the example I'll give is having worked with a lot of extreme parts, and particularly suicidal parts. So a part of a person who wants to kill themselves. And by going towards that, by interviewing, by really getting to know, hearing the nastiest, gnarliest components of why that part feels like this is its only option. Every time, and I have many IFS colleagues that say the same thing, every time we get to a suicidal part, feels like it's the last way to prevent more suffering or just to end the suffering. And surprisingly, well, at least at first, it's no longer surprising. But as that part shares with you or shares with the person their experience and they feel heard and seen, it de-escalates the intensity. It lowers the urge. It actually opens up more options. So that's one example. Another example can be really useful. Someone might come in and you're talking about a number of things, and there's this thing that's taxing me at work, and there's this thing in relationship, and they can feel really overwhelmed, and I can see that they're starting to panic, say. So I would invite them to relate to the panic or to the overwhelm as if it was someone in the room. And if we had more time, we could do, it takes a little chunk of time to get into it, but to actually see some of this unfold, which there are a number of sessions or parts of sessions available online. And I would suggest watching Dick Schwartz's work, and he's worked with some pretty gnarly parts that the client had made available. By working directly with that part, it creates, it's a relationship versus like kind of having to run away or get away from it. I'm not asking you, David, to trust me, just move towards it. But I do strongly encourage you to see how intensities can shift. And actually, I do invite you and everyone to notice what it's like for yourself if you get a glimpse of something that you're really resisting, pushing away, what it's like to turn fully towards it. You might notice that it actually frees up energy from trying to get away or push away or not see it or make it go away. And even that a slight shift in that can then add a little bit of more momentum and deepen that relationship. And it's no longer surprising that to notice, witness, help facilitate intimacy or conversation with extreme parts, learn why they're doing that job, and things soften. And actually, I want to just toss in a very important piece. It's a big part of IFS training, and it's available to anyone at any time, is checking in as a therapist or just as a person in a conversation moving throughout the world, noticing what parts are arising. So a big part of my work when I'm with a client, with or without psychedelics, is noticing what's arising in me. And I'm in I got a lot of relationship with different parts that arise and be like, oh, there's a voice saying that I'm not doing enough in this situation right now. Or I know this turning towards panic has worked before, but are you sure this time? I see you, I feel you. I can even locate things often in my body. And by me staying in self, it's one of the best things I can offer to a client with or without psychedelics.
All right, and I'll actually say on what you were talking about, Nick, about resources online. I know Dick Schwartz has several guided meditations available. If there's a free app, Insight Timer, he's got several IFS meditations on there that are, 8 to 15 minutes generally, on different themes. So if you're looking for something kind of experiential, that's a free resource in addition to what Nick was talking about in terms of IFS sessions. So the next question I have here is Matt Lokia. Sorry, it's all one word there. Not quite sure, but if you want to ask, oh shoot. Sorry, just give me a minute here to unmute.
Hey, yeah, I'm Bess. I'm a psychiatry resident. That's the name that comes up on my iPhone. Thank you so much for this talk. I love IFS. It's personally been really transformative and powerful for me. It's one of my favorite modalities for working with myself. So I love that we're talking about this. I'm wondering if you could say more about how you work with the system to prepare the system and how to really get good permission and buy-in from the part so that you aren't getting sort of whiplash or payback from, from firefighters or protectors or managers that are might feel sort of that you bypass them, or how do you really prepare that ground for this work?
Yeah, that's great question. There's a number of ways, and I'm going to start with right before we work with ketamine. So we've done, and I'll come back to the preparatory sessions, but know that, and my clients know that we have a ketamine session on the books, and that day we have built in kind of we'll check in, and we'll have them check in and go inside, check in with their parts to see, is ketamine still a go for today? And they're under no obligation. I don't have to pay for 2 sessions if they say no. We're checking along the way, and then I'll just keep going in that direction and then come back. During session, we can be checking in, or I do check in with parts along the way. Something that might have come up during preparatory sessions. And at the end of sessions, we can check in. And of course, in integration, I'm tracking and checking in with parts and literally asking them to go inside, find that part located in their body. How are you feeling towards it? And getting more information from them. So now back to the prep. Besides the informed in consent, of which I tend to repeat myself in just to kind of hammer points home, we again are checking in, and even if there's I don't kind of let people or systems off the hook if they say, nope, I've done psychedelics before, I'm good to go. We slow it down, and I'll even ask someone hypothetically, if there was a concern, what might it be? And that can be just enough invitation that this one part that was hiding behind or was behind a kind of a macho part or some other part can say yeah, I've done psychedelics, but I've never done this before. So there is a part of me that's a little concerned. By setting up the space, letting them know different things that could happen, and really kind of cultivating the intention of working with whatever's arising. And I can say with a lot of confidence, and it tends to come off in working with clients, that that we can indeed work with anything that arises in their experience. And then, as I mentioned, the time piece, the short half-life, some find that reassuring. And one other thing about getting buy-in, sometimes it can seem like all parts are on board, ready, they're ready to go. And other times, more often, there's parts that are I don't know about this. And I don't want to call it partial buy-in, but it's enough that they can trust that for this hour, they're going to be in this room and the safety precautions are set up, and they're not signed up for 6-8 sessions, that it's going to be here. And so there's often different negotiations with what different parts need. And if I just reiterated one thing of everything that I said, is slowing the process down so that there's space and the invitation to hear from these parts. Is that helpful?
Shoot, I think I might need to unmute. Yeah. Okay, sorry. Zoom etiquette rules here. Charlie, I'm going to get to your question after I ask my own question. I have many questions I wish I could ask, but I'll try to keep it short here. We were chatting briefly before we got started about group therapy or couples therapy. And that's a topic that we've talked about at various points in YPSG. And I'm curious, with IFS, how that works. And then if you add psychedelics, whether it's MDMA or ketamine potentially, I'm not quite sure what people are exploring in that regard. So just kind of all things couples or group therapy, I'd be curious what your thoughts are on that.
Yeah, as you know, we're both very interested in this. My thoughts on it, that, well, in no particular order, the need for it for a couple reasons. It's more cost efficient, so that's just a reality. Someone working one-on-one with a highly trained practitioner is going to cost a lot more. Another thought on it is the social and the relationships from working with a group. As many of you probably know, many psychedelics, kind of the culture of the traditions in which they were brought up, were sitting in circle or sitting in groups. And there's relationships formed and there's ways of supporting people along the way that is missing out on one-on-one. Pre-screening, not a register and come on in, but rather my caution would be around trained clinicians and medical staff, of course, in the room, because there can be a number of things arising. So training, good numbers to work with, the amount of people there. I can speak from experience not in a group, not yet. I was getting lined up and COVID said, not yet. But I have been working with couples with ketamine, low dose ketamine, and that has been really useful, even though their doses were kind of different. And that was a little thing along the way of trying to get them in the same optimal kind of window together. It was a heart opening, access things and work through some challenges while working with ketamine. So I've seen it work very well with couples, and I'm pretty confident that groups will. Actually, I have worked with ketamine in a group. In some of my training, there would be a rather decent sized group, and afterwards each person would have a person with them, but afterwards we would share what was coming up, and you can imagine some of the themes popping up, and kind of some vicarious learning, maybe even healing happening from across the room. So I am a big fan of working in groups, and I hope to be turning more time and attention to making that happen.
Got it.
And I'm curious, what are your thoughts, Rob?
Oh, I mean, just coming from a place of being a relative novice with these things, but it makes sense to me that MDMA assisted couples therapy, layering in IFS on that makes a whole lot of sense. I don't have nearly as much familiarity with the ketamine experience and trying to figure out how you could navigate that in a couples or group session. But it certainly makes sense to me that MDMA, that kind of bringing forward that self energy and the compassion and curiosity for one's own parts, as well as another, your partner's parts, being able to, like, that interpersonal self-energy aspect, if you will. I can definitely see MDMA fostering that and being really conducive to that end. But take it with a grain of salt coming from a medical student at this point, with not a whole lot of clinical experience. Anyway, I'm gonna be considerate of folks' time here, so maybe we can just have a couple more questions. I think we have 3 more hands raised, so we'll probably stick with that. And hopefully you're asking a concise, reasonable question here. But anyway, so Charlie, you're going to be next, so I'll unmute you, and if you want to, feel free to turn on your not your microphone, but your video as well.
Yeah, sure. Thank you very much for your presentation. I'll be mindful of time. 2 quick questions. 1, how do clients make their way to you? Are they individuals who have been unsatisfied with a variety of treatments and are looking for something else? Are they referred? Why would they go to see someone for medication assisted treatment? And I have a second question about IFS, but I'll hold off on that.
Sure. So first one is, it's pretty quick. All those reasons. People that have tried a lot of therapies, people that have heard success from someone else, read an article, were referred by their clients who were adjunct with a number of other therapists, meaning they have their ongoing therapy with a therapist, and then we do a program or a set of sessions with ketamine together. So therapists are referring their clients as well.
Okay, that makes sense to me. Second question is about the self. This is IFS. About the self. How do you, because this may not have been something that was discussed with clients in therapies prior to coming to you about self parts. How do you introduce that? How do you get them, let's say, to buy in so that you can begin the process?
Yeah, good question. There's several ways. A percentage of people come knowing an IFS specialist, so they have some understanding. But for those that don't, I might be an exception, but I rarely like, hey, this is IFS, and kind of talk about the model. We'd rather just by helping them identify different parts. And I may or may not use the language of parts, or hey, you were talking and then I noticed you kind of interrupted yourself. What happened there? And we'll kind of slow it down, and then I'll ask questions how they are feeling about that part. And at some point along the way, they'll start to establish more of a sense of when they're in self, whether we've talked about it or not. But because of the utility, more often or not, it tends to, the conversation does go there. They might have their own name for kind of that energy. Well, that's just me. And so it need not be spelled out.
Yeah. Oh, okay. I'd love to talk with you more about the concept of self, but I want to be obviously conscientious of time. And you said earlier, there's a kind of a multiple personality element to this. And I don't mean that in a pathological way. It's just that we all have different parts and different parts of our personality. But I want to thank you very much, and I'll move on. Thanks.
All right, got it, Charlie.
All right. Thanks, Charlie, for your questions. So 2 more. First, I see Steve Thayer. I'll unmute you here.
Yeah, can you hear me?
I can.
Sort of piggybacking on Charlie's question, how many sessions does it typically take for them to kind of get the concept, the IFS concepts, that you want them to understand before you start with ketamine?
Good question. A minimum 3 is what I work, minimum 3 prep sessions. And while I certainly will have practice in connecting with different aspects of themselves, they may not have ever heard of IFS even by the time we start working with ketamine, but they will have had experiences of unblending or working with parts, asking things to step aside and noticing that there's this presence that can notice different aspects. There have been cases certainly where, we're 2 sessions in, or just kind of getting honed in on even in an early phone call, maybe getting a sense that someone might not be ready to work with ketamine after a couple sessions. So there's an intuitive piece, and of course I'm checking in with them along the way. It's really hard to, it doesn't end up being about necessarily the number of sessions.
And since, IFS isn't, it sounds like it's not a very structured, protocol-driven kind of therapy necessarily. It's not like you're going to get your 12 sessions and then you're done. With ketamine, is there an expectation that you give them that, like, we're going to be doing 6 ketamine sessions? If you need further therapy or integration, I'll refer you to another therapist. Do you then see them for a longer time? Like, what's your approach?
Sure. So it is why I'm working more as adjunct to with ongoing therapy. If I was just starting my own psychotherapy, I wouldn't be of a mind that, I'll just do 2 months of ketamine assisted and that should like nip it all. So that can be, it's actually why we need a lot more trained clinicians in ketamine and IFS and soon MDMA, is because this doesn't scale very well. Someone might set out to do 2 months worth of work, or one set to be determined set working with ketamine, and then it opens some things and they want to continue. They've established a relationship and they want to continue. So I tend to leave my schedule open for that. And then as far as the amount, there's been some research, some of the earliest research was around, it was mostly with intravenous, and there wasn't a therapeutic component. And the research found that there were these improvements when getting 2 to 3 in intravenous infusions for 2 or 3 weeks. Which ended up being around 6 or 8 ketamine infusions. So there is no generally accepted standard of like how much ketamine or how many sessions. So what I've found is certainly to guard against some like open-ended idea of working with ketamine or MDMA or any substance, that the number of between 4 and 8 tends to come up. People know that they can, they can stop working with ketamine at any time. But the number that I kind of gathered both from the research and from my training and have been, and from my experience of working with people, the standard I kind of start at is 6, and then feel in and do it from there if it's better suited for a few less or a few more.
Wonderful. Thank you.
Mm-hmm.
All right, and last but not least, we have Shelley. Amen.
To unmute. Can you hear me?
Yes, I can.
Okay. So wonderful talk, really sort of intuitively appealing. And I heard a lot of things that kind of echo from transference focused therapy, kind of viewing from inside and outside of self and looking at all the resistance that come up with like personality disorders, which certainly are strong forms of resistance. 2 quick questions. If you don't want to answer both, I respect your time limits. One is when you do the couples therapy, can you explain a little bit? Are they both undergoing the treatment with ketamine or MDMA at the same time and then interacting while in sort of the altered state? Or is this done sort of offline and then therapy later? And then the other question I have is, what is your dropout rate? And what kind of things come up that make therapy difficult to continue, that it just really isn't the right time?
Okay. So thanks for the questions. For couples, while MDMA was, before it scheduled, was really useful for working with couples, is maybe some can imagine, and will be again when it's rescheduled. I do not work with couples with MDMA yet. But for both, I do with ketamine, and for both, and I'll just speak to what my experience. I've done both where one half of a couple will be working with, I'll have ketamine with the ketamine, and more often both of parts of the, I was trying not to say parts, both members of the couple will work with ketamine. And then just to add the IFS layer onto that, and there's some video of Dick working with couples as well. That can look a couple ways. It can look like the therapist working directly with one person and the other person kind of being witness to this, learning about the younger parts of their partner. And that can be not only healing for the person who's doing that work, but also just cultivate a lot of compassion for the one witnessing. For an answer, yes, it can work both ways. If one particular part of a couple can work with the ketamine and the other not, or both. And your other question?
The question related to dropout rate or things that
yes.
cause treatment to derail?
One dropout was someone who moved, an artist who moved somewhat unexpectedly, but we had some time to close around that. And I'm actually kind of draw from what I've heard from other colleagues. Give an example of a friend who went to a ketamine clinic. So this is just the biological, there's not a therapeutic kind of component to it. And they did not like it. They had signed up for a couple and they just didn't have a positive experience and didn't go back. That hasn't arisen yet in working in the way that I do. But I'm sure there can be people have bad or scary experience with ketamine. That I think would be the reason I think they may not be into it. Sorry, I'm kind of glad I don't have a better answer, but not a whole lot of experience. But I certainly wanted to give you something.
Well, I think that's it for our questions and our time today. Nick, I want to thank you again so much for sharing your time, energy, and expertise with us. I know I'm super grateful, and I just from the questions and the comments in the chat, I think a lot of people found this super informative. So really appreciate you for sharing your time. For folks who aren't on our mailing list and want to get on it, just search. We have a webpage, so if you search the Yale Psychedelic Science Group, you can find our webpage and sign up for the mailing list so that you can be kept up to date on whatever meetings and events we have coming up, as well as find recordings of this talk, which we'll hopefully be posting shortly. So with that, again, thank you all for coming. Nick, thanks so much for the awesome presentation. And I hope to see all y'all soon. Have a good night.
Thank you, Rob. Thank you, William. Thanks, everyone.
Thanks a lot, Nick.